My name is Dr. Daniel Fox, and I'm a licensed psychologist in the state of Texas and an expert in the area of personality disorders. And because October is Depression Awareness Month, I thought I would make a video on depression and borderline personality disorder. And I think the most important thing to know is that depression is different for those who are diagnosed with borderline personality disorder. And we're going to talk about that today. We're going to talk about how it's different, what those similarities are, what makes it complex, as well as medication for depression, how that tends to impact those with borderline personality disorder, and treatment. So let's get started, and I hope you enjoy the video. So first thing, what's important is that a lot of folks that are diagnosed with borderline personality disorder, as well as those with traits, are at a high likelihood to experience depression. And now when we talk about depression, we're not talking about sadness. Sadness is very different. Sadness tends to be short-term, tends to be trigger specific, which is there's something that has saddened you, which could be the loss of a relationship, things like that, but it doesn't last for weeks at a time. It doesn't impact your ability to function throughout the day. Okay, when it starts to do those things, last for a long time, impacts your relationships, your ability to go to work or school, connect with other folks, then we're talking about depression. And depression, just like borderline personality disorder, is also on a continuum. Okay, so you can have mild, moderate, severe, and extreme depressive symptoms. So the complexity with borderline personality disorder, and it's really common to see it in those that have borderline personality disorder as well as traits. And what the research shows is that 83% of those that are diagnosed with borderline personality disorder also meet criteria for major depressive disorder. And that goes to our depression, not sadness, but goes to depression, which means that it does impact what's called socioeconomic dysfunction, or causes socioeconomic dysfunction, which is that inability to relate to others, connect to others. Sometimes it's hygiene issues, taking care of yourself, sleeping. And depression, a lot of people think that depression is just sort of a very sullen and dropped mood. There is also what's called agitated depression. And agitated depression, that is when people are very irritable, frustrated, agitated, and a lot of times you see depression with what's called anxious distress. And that is that they have all this energy, this pent-up energy, and it's a frustrated type of energy. But there's a depressive overlay to it. And it's really complex, and that would take a complete video on its own to talk just about depression and how that interacts with agitation. And I want to stay consistent with borderline personality disorder here because I think this is really important. A lot of mental health providers are also confused by it, certainly with the presentation, and those who don't specialize in personality disorders can be very confusing. So let's try to simplify some of that now. So when we talk about borderline personality disorder and major depressive disorder, there is significant symptom overlap. And the symptom overlap, what happens is that those with borderline personality disorder, that they tend to have a sullen presentation that mimics depressive symptoms. Okay? Certainly suicide risk, self-harm, which is also seen in those with a major depressive disorder. There's affective instability in those with borderline personality disorder and traits. And this manifests, because we're talking about depression, that overlap, that's an intense episodic dysphoria, okay, when we see it in borderline personality disorder. But also, you can see some of that, remember we talked about anxious distress, you can see that as well. Because you can see folks that are presenting with this very sullen, dysphoric, sad, melancholic presentation, but it's frequent temper outbursts in these folks, agitation, irritability, this mimics that major depressive disorder with anxious distress. Okay? And individuals with borderline personality disorder tend to experience senses of emptiness, which is also commonly reported in those with major depressive disorder. And then there's also this stress-related paranoia for some of those folks that are on that borderline personality disorder spectrum, and they have dissociative symptoms. And this mimics depressive with psychotic features at times. Now, depression with psychotic features, that is those that are so depressed that they start to hallucinate. And that can often be confused. Some mental health providers can be confused and think that it is hallucination and delusion, and it's actually dissociative episodes. So we have to educate ourselves, certainly as mental health providers, but also as individuals that experience this disorder, so that sometimes we have to clarify what symptoms we're actually seeing, and we're going to talk more about that in just a minute. Okay, so that's that symptom overlap. Well, depression and borderline personality disorder, but it's not actually a depressive disorder in some cases. So let's talk about that real briefly. So now we know that depressive symptoms, because 83%, depressive symptoms occur in those with borderline personality disorder. But in those with borderline personality disorder, if it's not depression, okay, so now we're going to step outside of major depressive disorder. And this is for folks that just have borderline personality disorder, okay? Not just like I'm minimizing it, but just that it's not comorbid, which means it occurs together with major depressive disorder and borderline personality disorder. So these are just folks that only have borderline personality disorder. And if they don't have major depressive disorder, what you see is you'll see an identifiable stressor, okay? And this is an instance which could be rejection, perceived abandonment, some type of issue. But what happens is once that episode, that identifiable stressor remits or attenuates, which means that it goes away, it resolves, you see that those depressive symptoms, that depressive presentation also remits and starts to lessen, okay? And so you're seeing it's more situationally based than it is long-term for extended episodes or periods of time, okay? So that is how we know that someone with borderline personality disorder does not also have major depressive disorder. Now that doesn't mean, right, remember, because they're on continuums, we're not talking in absolutes, okay, that there are changes. But that's what we look for as mental health providers. For those that have borderline personality disorder, when there's an identifiable trigger, those with BPD tend to experience or tend to present with emptiness. You can have increased agitation, which is what we talked about a minute ago. But when that trigger or that episode, I don't want to use the word episode, when that trigger or that issue that caused that sense of rejection and abandonment, when that is resolved, so maybe the relationship restores or the fear is then attenuated or lessened, those depressive symptoms go away with it, okay? But now what happens in individuals with BPD and with depression, these symptoms can be an issue related to the communication of feelings. About a lot of folks with borderline personality disorder have issues expressing their emotions, communicating them clearly. And this can include anger, frustration, helplessness, disappointment, and all those other things. So a lot of times what we see, and part of this confusion for mental health providers as well as for yourself, if you're experiencing BPD or if you have a loved one or someone you know who has this, is that they don't communicate their emotions well. They have this difficulty in doing that, okay? And so these states don't respond. What happens is that they may go to their primary care physician and they may report, well, you know, I've had this loss of a loved one, whether it could be death, end of a relationship, whatever it may be. So you go to your primary care physician, let's say, or even a psychiatrist, and you report these episodes, these criteria, you start to explain it. And they're like, oh, well, this person's obviously depressed. Okay? Now they don't know about those other fluctuations, they don't know about the nuances and overlaps and other factors that we're just getting into. So they diagnose their patient with depression and they give them medication. The problem is that the medication doesn't really remit those symptoms. Okay? And we're going to talk more about this in just a little bit. So what happens is that we have to educate the individual. This is why therapy is so important for those with borderline personality disorder, because we have to teach these folks, right? Or we have to learn how to communicate our feelings. Okay? If you're one of those individuals that you have trouble kind of expressing your feelings, I do have an emotions exercise on my website. You're welcome to download and try it to try to build up your emotional intelligence skills, your communication of emotions, which is really important because if you have these seemingly depressive episodes that are trigger related, okay, then you need to be able to communicate that to identify those emotions specifically with that trigger. And if this is confusing, we're going to keep talking about it to try to clarify it for you, but it is a confusing process even for mental health providers. So if you're confused, it's understandable. Okay, so let me just simplify really quick. So what we're talking about is that the confusion for the individual as well as the provider of care for those with BPD is that the individual with BPD has trouble effectively communicating their emotions. They've experienced a trigger or loss, so they start to express certainly feel and are managing and dealing with these depressive-like symptoms, but they don't qualify for major depressive disorder, which is where medication is helpful. Okay, so let's keep going, because there's even more of a question. This goes to the complexity. A lot of folks who write me and stuff understand, because they're living it, the complexity of BPD. Okay, and it is complex, and but it's not a lost cause. And I always try to add that, is that this is a treatable disorder. It really, really is. Let's go a little further, because it used to be believed that borderline personality was what's called an affective disorder. And an affective disorder, that would be your depression, all right? You also have an affect, an emotional component, right? So they used to believe that BPD was like bipolar disorder. And I've contemplated doing a video just on bipolar disorder, and I'm not going to get into bipolar disorder here because of all the details that's in that is composed of bipolar and the difference between borderline. But I'll lightly touch on it here so that you have some clarity. So what happens is BPD is often confused as an affective disorder. This could be bipolar or depression. But what happens is the proof is in the treatment of depression does not lessen those BPD symptoms, okay? So let's say you have an individual who has major depressive disorder that is comorbid, so they occur together with BPD. That individual goes to their psychiatrist, their primary care physician. They get, let's say, Prozac or an SSRI or another medication for depression. What will happen is you may see those depressive symptoms remit or lessen, but the BPD stuff still is present. Those fluctuations, that agitation, that anger, that emptiness, that chronic emptiness, that fear of abandonment, those other factors don't remit. They don't go away with medication. Okay, so that's a big indicator. All right, that what we're talking about is BPD that could be comorbid or could not be with major depressive disorder. Goes for bipolar as well. You'll see that those manic phases, hypomanic phases, and those depressive episodes become attenuated or controlled or steady, but you still have those reactions, those BPD feelings and other types of factors. And we're going to talk a little bit more about medication and attenuation of symptoms in just a minute. All right, so, but here's what's interesting, and this is what the research shows, is that treatment for depression doesn't lower BPD symptoms, but BPD treatment for BPD lessens depressive symptoms. Right? I mean, think about it. Because the manifestation of those depressive symptoms comes from BPD. If you deal with BPD, you can manage the depression. But if you just treat the depression, it doesn't lessen the BPD, because the BPD is a larger component that is over the depression, okay? And I'm going to get more into it, so don't get frustrated. I'm like, what the hell is this guy talking about? I'm going to clarify as we keep going, okay? So what's interesting is, so we also want to talk about early experiences, okay? We're going to diverge a little bit and talk about those with BPD that have these early experiences. And the early environments, okay, for a lot of folks with BPD, but not just BPD, okay, that have had insecure attachment patterns combined with anxious, sensitive temperament, later childhood trauma, which could be abuse, psychological abuse, emotional abuse, other types of abuse factors that may predispose individuals to BPD and early onset depressive disorder, as well as dysthymic disorder. Now, dysthymic disorder is, so here's depression when we talk about a severity. Dysthymic disorder is not as severe, but it's this continual sort of feeling, right? There's no other way to describe it than folks who just feel blah. They don't get excited about anything. Everything seems kind of very sullen. And this is not meant to be humorous, it's meant to be as an example, but there used to be someone on Saturday Night Live called Debbie Downer. And so Debbie Downer, she presented with something similar to dysthymic disorder. Never really happy, tends to be overtly negative, tends to not enjoy things, a lot of anhedonia, which is that you don't enjoy things, you don't enjoy experiences you have, you tend to lose interest in things you once enjoyed. But this happens for a longer period of time. But it's not as severe as your major depressive disorder, okay? So let's keep going. Okay. So now we've talked about early experiences. Let's talk about medication, because this is very tricky. In the United States, 70% of all actually of the world's medication is consumed in the United States. And what's interesting as far as medication is that there is limited research that actually shows evidence for the use of Abilify or Zyprexa or omega-3 fatty acids in the management of depression as it is a component of BPD. Okay? But the problem is there's no real solid data on how to guide clinicians or psychiatrists or primary care physicians in choosing a specific treatment for depression that is comorbid with BPD. Okay? Now, there is increasing pressure right around the world, okay, about the limited use of medication for BPD. Okay? Because of its limited effectiveness and concerns about obesity, which is an issue a lot of times with medication. Other types of health problems can occur due to long-term taking medication that you need to talk to your doctor about. And when we have an individual with borderline personality disorder that also has these comorbid disorder, we're just talking about major depressive disorder in this video. Okay? So what happens is that you don't have a lessening of your BPD symptoms. So you go back to your doctor, okay, and you say, well, I mean, you know, nothing's really changed. I'm still depressed. I'm still agitated. I still have what we're calling anxious distress. You know, so what happens is they give you another medication on top of the other medication. This is called polypharmacy, okay? And so, and if you've listened to my other videos, you've heard me talk about core structure and surface structure. That's exactly what we're talking about. Now, surface structure would be your depressive episodes and features and criteria and components. Your core structure is that BPD, is that borderline personality disorder. Your core structure, okay, drives or impacts your surface structure, okay, which in this case, we're talking about major depressive disorder. Now, if you can attenuate, and you have to deal with surface structure behavior, but that core structure is still present. So in therapy, because medication addresses surface structure, does not address core structure. It would be great if we had medication for personality, but we don't. So that's why treatment, and this is research that's been done since the 50s, that has been found more efficacious than medication, even as medications get better. Now, I'm not saying don't take your medication. Please don't. You have to talk to your psychiatrist or your primary care physician. This is not a video about should you take your medication at all. You need to talk to a mental health provider or a medical provider. And anytime you're thinking about changing your medication, that's really important because you're dealing with your brain and your body, and you don't want to have different types of side effects and abreactions if you make those choices, okay? So let's just be clear about that. So when we talk about polypharmacy, now what happens is that you're getting medications, again, so for surface structure, your medications are being prescribed to deal with these different components: agitation, depression, loss of interest, lack of drive, other types of factors. So this polypharmacy starts to occur, which is you're getting prescribed different medications for different symptoms. So now you can have 4 or 5, I've had clients that were on 9 different medications to deal with symptom presentations related to BPD. Now that doesn't mean they weren't comorbid with anxiety, PTSD, other things, but their core structure of BPD kept driving this surface structure. I really hope that this is making sense, and I know it's complex, so I'm trying to go slow and be clear. So polypharmacy. Now this tends to occur, again, because you go to your doctor, you're in distress, and that's all right, right? You want something to feel better. Your doctor wants to help you, right? So they're driven to try to manage and alleviate these symptoms as best they can, right? So as you present with more symptoms, they are identifying other medications that might be able to help you, okay? And now one study found that compared with people that just had depression, okay, people with borderline personality disorder were twice as likely to have taken antidepressants, 2 times more likely to have received an anti-anxiety medication, and more than 6 times likely to have received mood stabilizers, and they are more than 10 times likely to have used antipsychotics. Okay? So that says a lot. That goes right back to the client example I gave you, is that you're presenting with different symptoms, your doctor wants to help you, they're driven to help you, and they keep seeing these symptom presentations, so they're addressing each of those symptoms with different medications. Okay? But the core structure stays, which is why therapy is so important, okay? What this means is that you want to explore your options with your doctor and do your best to have a treatment team if you can, okay? So as a psychologist, I have talked to primary care physicians, psychiatrists, and we have been a treatment team, sometimes of 2, sometimes of 3, to help this individual get stable, function, and as you build these abilities to manage, define, understand your emotions, then you become more empowered and efficacious, which is my goal for a lot of my clients that have personality disorders, is empowerment, insight. You need less medication because you're building these skills to manage it. But they're being treated by a psychiatrist, by myself as well, and sometimes there's a caseworker, sometimes there's a social worker, sometimes there's a licensed professional counselor, an LPC, so that we're helping this individual build these skills, interact appropriately, and the medication is not needed as much. So you can start to lessen some of those over time. Perhaps they go away, and you don't need the medication. Now that's in some cases, and again, you don't want to do this on your own. You want to do it with medical providers, with mental health providers who actually know and can help you and give you the support that you need in order to do that, okay? So let's talk about a little more. What about medication or therapy? Okay, so now research has shown that major depressive disorder is not a significant predictor for outcome of BPD. We talked about that, right? Is that if you treat depression, that doesn't lessen those borderline personality disorder symptoms, criteria, other factors. But borderline personality disorder is a significant predictor of outcome for major depressive disorder. So if you treat the borderline personality disorder, that can lessen, and successfully, and you start to lessen some of those surface structures, surface presentations, issues, that will lessen the depressive symptoms. But lessening the depressive symptoms and saying, well, the personality disorder, we're not going to worry about that, we're just going to treat depression. The BPD stuff still stays there. And you may have had this experience, okay? Is that you're on different medications and you're like, well, it's not changing all of this. That's because this is BPD. But it's changing this, which is the depression. Okay, so now these studies, right, so what they found is that they recommended the treatment of borderline personality disorder, okay, with psychotherapy. And what should happen is the priority, so when you have this major depression and you have BPD and they co-occur, so they're comorbid, when they occur together, that the mental health provider, the treatment provider, the psychotherapy shouldn't focus on the depressive symptoms, but focus on the components of BPD, which goes back to dealing with that core content stuff that we talked about, as opposed to just dealing with surface structure. But, and I will say this as an aside, if you have severe, extreme, high, moderate depressive symptoms, these folks tend not to show up for therapy. They're too depressed, they're not motivated, therapy tends to have no forward movement. So that's where medication can help a little bit. You can attenuate some of those depressive symptoms enough to get the client or yourself motivated to come to treatment to deal with the BPD, because if we can control and lessen the BPD, we control and lessen the major depressive disorder, okay? So now different psychotherapies have been found to be really effective for borderline personality disorder. There's cognitive behavioral therapy, there is DBT, dialectical behavioral therapy, there's interpersonal therapy, and others that are found to be really effective, okay, to deal with BPD, lessen the symptoms of BPD, and get those under control, okay? And so what we want to do is, if in these treatments, and this is for yourself as well, these are some skills for you to build, okay, along with your mental health provider. If you can't afford it, these are some skills that you can try to build on your own. I have different worksheets on my website. There are different workbooks. I have a workbook coming out next year in 2019, specifically related to my theory and approach with individuals with BPD on how you go through this, how you first deal with some of the surface structure, building some skills, then you go to your core content and you start to address your core content, control your core content, build skills to manage it, and then how to achieve a maintenance phase as well, okay? But so what we want to do is, just briefly, so what are some things that you can do? Okay, so we want to build awareness of emotions Okay? So if you're someone with borderline personality disorder or someone you know has borderline personality disorder, work on emotional definitions. Okay? So what is happiness? What is sadness? What is anger? What is frustration? Anger and frustration are very different, right? Now you can have frustration, but then you have anger. So there's different levels. Building that understanding so that the individual with borderline personality disorder, they can say, well, I'm frustrated. Instead, a lot of folks with BPD say, I'm angry, 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 angry. But really there's a nuance in there, and building that differentiation between that is so important. Okay? And what we want to do is you want to not only build awareness of emotions in self, but in others, and then identify situations that trigger an emotional response so you understand not only yourself, others, and situations. And this takes time. I love Daniel Goleman's first book on emotional intelligence. I think that it gives a lot of good examples. I don't think he meant to do this, but as a mental health provider, when I read it, I'm like, these are great techniques. Again, I have an emotional exercise on my website. You can check that out. Build these skills. The more you do it, the better you'll get at it. And another way to try it is like you can watch different YouTube videos or different movies, and as you're watching it, say, what emotion would I say is there? And if it's anger, sadness, whatever, frustration, maybe ask your partner or friend, whoever's with you, and say, what emotion would you say that is? And now you're getting some concurrent validity. You're giving yourself a little bit of emotional understanding, okay? And that's important to do. We want to do that. So as you start to recognize your emotions, it helps you to learn to control them, okay? Now, what we want to do is we want to, as we've talked in here, right, in this video, is that we want to increase awareness of your emotions. We also need to recognize that treating depression tends not to, and the research that supports this, does not attenuate BPD expressions. But if you work on BPD expressions, they're just symptoms, criteria, other factors, that has been found to lessen your depression, okay? And that's important. And these are important things. These are important skills and awareness and insight for you so that you can help to manage your condition or help a significant other or a child or someone you love that's experiencing these borderline personality disorders, as well as those traits. Okay? So I really hope that this has been helpful for you. I hope it wasn't too much information. You know, the video could really go for like 4 or 5 hours just on this topic, and that's a really long YouTube video. So I tried to make it specific and condensed, and I hope that you enjoyed it. If you like this video, you're welcome to check out some of my others, and I appreciate your time and attention, and thank you very much, and have a great day. Take care. Bye-bye.